Hello, and welcome to the Ovarian Club, a glimpse into conversations between two besties across countries, South Africa and France, tackling the trendiest women's wellness topics through a scientific lens. Join me, Dr. Tarryn, and health expert Emma as we explore delicate subjects related to the women's health space. We started this podcast to share our conversations to help navigate the complex women's wellness world. We hope you enjoy the podcast and take away as much from it as we've enjoyed making it. The Ovarian Club, powering life, nurturing health, shaping sustainable wellness. So, my follicle friends, let's begin.
Hey, Sa.
How's it, Em?
Good. I am currently dealing with some jet lag and a little bit of sinusitis, but my full dedication to be here and really happy and excited for this next episode.
Sorry to hear that you're sick, and thank you for your dedication. Yeah, we at the Ovarian Club really do strive to present high quality, up-to-date educational material despite how we feel inside. But yeah, I'm feeling well. Busy day at the clinic. Saw lots of patients in perimenopause. So really excited to discuss this topic today. Let's get into it.
So first of all, just thank you to everyone who has been listening in so far. We so appreciate your engagement, your questions that you've been sending us, the comments, your feedback. Please continue. Please do share any thoughts, feedback. Please also don't forget to subscribe and to follow us at the Ovarian Club. And yeah, just thank you so much. So here we are today, very excited to be speaking about perimenopause, as Tarryn mentioned. And I have to also just give a little disclaimer. Honestly, until very, very recently, I had next to little to no clue what perimenopause actually is, God, my grammar, my brain scrambled. Anyways, Tarryn, you sent me some podcast episodes to listen to, and I have to also be honest with you, I was totally freaked out listening to these podcast episodes, and I think you can totally attest to the wild messages you received from me and the phone calls that was pardon my French, but what the hell is this? What is going on? What is going to happen to me? So I'm really hoping that this episode doesn't do that for our listeners and does shed some clarity, but also provide some hope in this situation.
No, perimenopause is actually a beautiful topic to unpack. And I'm actually quite excited to embrace it. I'm already now, with the knowledge that I'm learning, taking measures for the future to best optimize my 40s and beyond. So I hope all the listeners also take note and not fear perimenopause, because as we'll soon discover, there's so many treatments available and we are here to support you all the way. Now, before we get into this episode, I just wish to disclaim that although I am a qualified medical doctor, the podcast does not serve to offer any personal medical advice. And while we at the Ovarian Club strive to provide accurate and up-to-date information, the content discussed should not be used to diagnose, treat any health issues or medical conditions. So, yes, disclaimers out the way. I think we can get into it.
Yes. So the first question, what is perimenopause? How does it differ from menopause, premenopause? What is it? Let's dig in.
So up until recently, even me as a doctor, I had to search for the answer because as a medical student, I received little education on the topic on both perimenopause and menopause, despite it being the one single thing that every woman on this planet will go through at some stage in her lifetime. How wild is that? It literally affects every organ system in our body. Yet perimenopause is as little spoken about as Nando's mayonnaise. Am I right?
Been a while since I've heard about Nando's, but yeah.
So in answer to your question, let's just as a quick recap remind ourselves that females are born with our ovaries, which ultimately we will outlive. Okay, so we are born with 2 million eggs at birth. And by the time we're 30, we have 10% of our egg supply. Quite a drop, right? And by the time we're 40, we have as little as 3% of our egg supply. So at menopause, by the time we reach that stage in our lives, the factory has shut down. And this age, on average, is 51, okay? But there is a great range from 45 to 55. So before I define perimenopause, let's just quickly define menopause. What is menopause? Okay. Menopause marks the official transition point. It's one day in a patient's life when her periods have stopped for 12 months retrospectively, in the absence of other medical causes.
I think people think about menopause as a long duration thing. I certainly did, but it's really interesting to know that menopause is just one day.
Its onset is, so it's not one day. So menopause is throughout a woman's life, but its onset is officially 12 months after the cessation of her last period. Premenopause is a question I think you asked me. This is the entire reproductive phase before both perimenopause and subsequent menopause, when menstrual cycles are still regular, ovulation occurs. Postmenopause, on the other hand, refers to the long-term stage after menopause. And this is met with a lot of associated health conditions, which I think we should absolutely tackle in a separate episode when we break down what menopause is. But in answer to your question, what is perimenopause? This is the transitional phase leading up to menopause, okay? And this phase is categorized by hormonal fluctuations of estrogen and progesterone. Both these hormones fluctuate at a rapid rate, up and down, and this leads to irregular menstrual cycles. And in some individuals, the onset of menopausal symptoms, which differ greatly upon the masses.
Okay. So just to kind of summarize, premenopause is basically anything from when a woman or a girl starts her menstrual cycle up until she hits the menopause stage. Perimenopause is when you have a sudden drop in the estrogen and progesterone produced by the ovaries at a certain age, which we're going to dig into. Then you have menopause, when you've had 12 months of consistent no periods and there's no other medical reason to explain why you don't have a period.
Yes.
And then postmenopause is later on, which has other host of symptoms after a certain duration of menopause period. Is that correct?
Yeah.
Great. So the perimenopause, when does it start and how long does it last?
Cool. So as we defined earlier, the average age of menopause is 51, whereas perimenopause typically starts 4 years before menopause. So say 47 years old would be the average age. But the symptoms can start appearing up to 10 years prior. So we actually say that in your early 40s, you may start experiencing symptoms of perimenopause. And if your predestined menopause date is actually earlier than the average, earlier than the norm, these symptoms can even begin in your late 30s. So very relevant topic today. But typically, yes, 4 to 10 years prior to the onset of menopause, very big range. And it lasts up until you have established menopause, which is 12 consecutive months of no period. Then you're in established menopause.
And is there anything to determine when you could maybe expect menopause, or why some women may be earlier than others, which then would determine why perimenopause would start earlier for some women, even in their late 30s as opposed to their 40s?
Yeah. So in answer to that question, there's a range of reasons why this is the case, but genetics plays a very big role. So it's always wise to ask your mother when she started experiencing these symptoms, if this is known to her, because it does carry a great genetic predisposition. But in addition to this, lifestyle factors also play a role. So if you lead a healthy lifestyle, you eat well, don't smoke, and then of course, so say you've received cancer treatment or you've had your ovaries removed. I mean, these are other reasons as to why menopause might kick in earlier. Autoimmune diseases as well, and some of the treatments can result in earlier menopause.
I know we're speaking about perimenopause today, but just selfishly, I did also hear that if you have PCOS, it could maybe trigger early onset menopause.
So the studies that I read actually alluded to the fact that patients with PCOS may in fact have delayed menopause compared to those without PCOS. This is possibly due to the fact that women with PCOS have a larger ovarian reserve, so more eggs compared to women without PCOS. And this larger reserve is thought to delay the depletion of eggs and thus delaying the onset of menopause.
So the literature is still out. So I know we've covered so much already in such a short amount of time. Let's just peel it back, go back to perimenopause. which is, as we discussed, when the estrogen and progesterone levels drop very quickly.
Fluctuate. So basically, if I can illustrate a diagram in our listeners' minds, in perimenopause, the hormone levels are going up and down and up and down. This is triggering mood instability and a range of the symptoms that we see. But by the time that you've reached menopause, they've actually fairly stabilized. They are still lower than pre-physiological levels before perimenopause, so they're much lower, but they're actually more stable. Hence why the symptoms of perimenopause sometimes in some women actually diminish when you're in menopause because the hormone levels have stabilized.
So let's actually dive into that right now then. The symptoms. What are the symptoms? You keep alluding to the symptoms, but what are the symptoms of perimenopause? How do you know you have perimenopause and not just some other hormonal disorder? Again, something also I was reading about in research is that it's very misdiagnosed, perimenopause. So a lot of women actually don't know that they're in perimenopause. They're having all these symptoms. They go to their doctor and they're just kind of dismissed, or it's dismissed as their midlife crisis or whatever it is. So symptoms, what are they? What can a woman be expecting that maybe is kind of a checklist to say, hey, this is something I maybe need to discuss with my doctor around perimenopause?
That is an absolutely brilliant question. I'm really glad that you brought this up because, as you correctly identified, patients are so disempowered. They don't even know what symptoms to report. And doctors similarly don't know what questions to ask because they are so poorly educated in perimenopause and menopause training. So let's empower our listeners. So the key signs would be irregular periods, hot flashes when the body feels hot and cold and sweating. Reduced libido is a big one. Patients no longer feel the desire to have sex. It could also be painful sex. That's another common symptom. Recurrent UTIs due to the drop of estrogen in the vaginal canal. And then you've got slower metabolism, so difficulty losing weight despite maintaining the same exercise regime, same diet, everything. You're doing the same, but you're just now actually putting on weight, and it's typically depositing around the abdomen. And it's really disconcerting for patients, especially those who are trying. Skin thinning, hair thinning, joint tenderness. You have mood instability, anxiety, depression. These are big ones. And often I see patients present in the clinic complaining of depression. They were never known with depression before that. So it clearly is due to the estrogen fluctuations, and often the treatment is not only to chuck an antidepressant at the patient, but rather to address their dropping estrogen levels, replenish those stores, and that actually improves the depression. Sometimes also in conjunction with a SSRI or antidepressant is needed.
Sounds like a lot.
Oh, yeah, right? But yes, mood instability, brain fog, reduced cognition, poor sleep is a big one. Our bone turnover isn't as great as pre-menopause, so joint and bone problems can ensue in the perimenopause stage. I think we've covered most of them.
So, I mean, it's a lot of symptoms, right? I'm going to summarize if I can. Hot flashes, irregular periods, you've got mood instability, or, you've got different mood swings, potentially depression or anxiety, muscle weakness, bone density decreases, although that's further decreases in menopause itself. Brain fog, it's a lot of symptoms. How do people, and I have to also honestly say, like, a lot of these symptoms also overlap with other hormonal disorders, like just speaking from personal experience, like a lot of that does also seem to overlap a bit with PCOS. And I imagine also sometimes brain fog is also due to mental load. These women are probably have children already or are entering a stage in their career where they have more responsibility or taking on things. How do we know that this is not just due to stress or due to midlife crisis? What are we looking for? What are we testing for? How does a doctor diagnose this perimenopause and not something else?
Yeah. So that's actually a very good question, because even as doctors, it's quite difficult to make a definitive diagnosis because blood tests looking at our blood hormone levels are typically unreliable because of the fluctuations that I alluded to earlier. So generally speaking, how do we go about this conundrum? If you are over 45 and you are reporting some of the symptoms that we alluded to earlier, then generally speaking, it's a clinical diagnosis. It's fair to say that you've hit menopause. I mean, 12 months of no period in the absence of contraception and other medical causes. Okay, fine. we know it's menopause. Whereas if you are in the age bracket between 40 and 45, it's actually a little trickier, especially if you're taking contraception, because you really can't look at hormone levels. But typically speaking, in the absence of contraceptive hormones, doctors would pull a thyroid test because thyroid conditions often mimic symptoms of perimenopause. Also, we'd look at prolactin levels, and then the follicular stimulating hormone and estrogen hormone levels can also be considered. And doctors must also exclude pregnancy when doing a workup for perimenopause. That's super important, because why you're not getting a period? Are you perhaps pregnant? So that must be worked up. If you are under 40, however, then it absolutely must be investigated. So all those women will receive all those blood tests and even more of a workup before a diagnosis of primary ovarian insufficiency can be diagnosed. So that's generally our approach. It's age dependent. It's dependent on whether on contraception. Not everyone gets a blind hormone panel. It's very much individualized, the testing and diagnosis. And another factor to take into consideration is that any woman who is experiencing irregular menstrual bleeding in the form of increased bleeding, so they're bleeding abnormally, lots of bleeding, that must absolutely be worked up. No matter the age, that must be further explored.
You mentioned obviously the impact of the pill and how that may also impact these different blood tests. Does the pill also have any impact on perimenopause at all, on the symptoms of perimenopause?
Great question. The pill, especially if it's a combined oral contraceptive pill with both estrogen and progesterone, can mask symptoms of perimenopause because you're receiving such a high dose of estrogen. So it can impact it. And if anything, it makes it more confusing for us clinicians to diagnose perimenopause because the patient is chronically not ovulating because their ovulation is being suppressed by the oral contraceptive pill. Their symptoms are being masked, which is great, but then we actually don't know where the patient's at in terms of her reproductive cycle. So yes, it can have an impact, but it does not have an impact on when menopause will ensue. That's determined by the genetic and lifestyle factors.
Yeah, but it could potentially make the symptoms more manageable by the sounds of it, right? If it masks the symptoms, does that mean it makes it more manageable?
Yes. Although women, when they're approaching 50, we want to slowly start tapering contraception because firstly, they probably won't require it because they are likely to be entering the menopause stages. But at the same time, we want to be very wary of the levels of estrogen that we are exposing to this subgroup of patients. And we'd prefer patients to actually switch to hormone replacement therapy, which is HRT, which is basically much lower levels of estrogen and progesterone. We would ideally want to transition them onto HRT because HRT will provide the patient with the hormones that they require, but at much lower, safer levels. But at the same time, consider their contraceptive needs. So it's actually a very, very difficult condition to manage as a clinician. And they say that managing perimenopause is much an art more than a science because certain modalities will work for some patients, other patients are on other contraceptives, and it's really just about individualizing the patient and seeing what works for that patient, given her risk factors and comorbidities.
Yeah, and I would like to get into the hormone replacement therapies in more depth. But one thing that you did tap onto is the need for contraceptives. And one thing that I read that was quite interesting is that during perimenopause, people actually sometimes stop taking the pill or they don't use contraceptives because they think that they're no longer fertile, able to have kids. And then you have these late stage full bundles of joy that pop up in your life later on unexpectedly. Yeah. And so I have heard that it is very possible to still fall pregnant later in life, even during perimenopause.
Yes, it's possible. If the woman's ovulating, it's possible. But the chances are very low if you're older than 45, but not impossible.
Then going back to the hormone replacement therapies. So I know that there has been some controversy around hormone replacement therapies. So there was the medical study, or you'll probably tell me what the actual name was, but it was taken off the shelves and people stopped prescribing hormone replacement therapies. Now it seems to be coming back and very effectively, and people are kind of swearing by this and saying it's changed their lives.
Yeah.
Can you explain a little bit more around that and where we're at today in terms of the norms or the prescribing recommendations?
Perfect. So, the study that you're referring to was the 2002 Women's Health Initiative study, which was a landmark study at the time that investigated the risks and benefits of hormone replacement therapy in postmenopausal women. And at the time, it was revealed that HRT, hormone replacement therapy, posed a great risk of breast cancers and cardiovascular issues like strokes and clots and heart attacks. And the study was instantly put to a halt. Funding was no longer diverted there. Everyone freaked the hell out. And that was it for HRT. And I feel like a whole generation of our mothers have now missed out on the benefits of HRT, because what was subsequently then exposed was that there were many flaws with the WHI study. The first flaw was that this study examined older patients already in established post-menopause. So they were above 60. We would never start a patient on HRT, 10 years post-menopause, so say from 60 plus. So the study was conducted on older patients who already had established cardiovascular illnesses. Maybe they might have even had established cancers. So they were the wrong population to examine, right? That was the first issue. Another issue was statistical reporting, because later on it showed that they grossly overestimated the absolute risk versus the relative risk. So basically, in summary, the Menopause Society has concluded that typical use of hormone replacement therapy, HRT, does not appreciably increase the risk of breast cancer.
Okay, I have so many other questions, but that's going to have to be topic for another time. But when would you start then a woman on HRT?
So this is very much individualized. Before starting a woman on HRT, I would take a full medical history. I would then interrogate the symptoms that she's experiencing. I would only start it if she's symptomatic for perimenopause. And then I would also review her contraceptive history, see what she's on. It's very much an individualized approach. But at the end of the day, yes, I would say if she's symptomatic in her 40s, it can be a conversation that we can initiate. And I'd also have to exclude the absence of contraindications. So just ensure that she herself does not have active breast cancer, because that would be a contraindication, whether she's got active blood clots, whether she has established cardiovascular disease, so poorly controlled blood pressure, if she's got active liver disease. Really, these are the only contraindications to starting hormone replacement therapy. Bottom line, doctors should not be afraid to start a patient, especially with the transdermal patch. So HRT is now being administered is actually transdermally, through the skin. So what happens is you put on a patch which secretes hormones. Then the hormones seeps through the skin into the body and performs its wonderful effects, counteracting the perimenopausal symptoms. And this patch can be applied twice a week, and it's very safe to use. So many patients would be great candidates for HRT. And I just want the world to know about the transdermal patch and how incredible they can be. I mean, they can come with some side effects. So some side effects would include irregular bleeding, which is at this stage would be irregular as it is because you're in perimenopause. Other symptoms that patients commonly report is breast tenderness, maybe headaches, whatnot. But generally speaking, super well tolerated. If the doctor and the patient can get that dose right, it's very much a conversation, right? Like you don't just give the patient HRT and you send them home. You follow them up. You see if you can adjust the dose, if they're happy on that dose, and you keep them on the lowest possible dose that can best manage their symptoms. It can improve their lifestyle. It can improve every facet of their life. It can improve their sleep, their hot flashes, their mood instability. Okay, maybe hair and skin, certain aesthetics measures can replace that. But yeah, hormone replacement therapy, from what I've seen and from what I've heard, can really be life-changing for a woman.
What happens if you're younger than 40 and you're starting perimenopause, as we mentioned previously, at like 37 or something like that? Could you also qualify?
Yes, absolutely. You would absolutely qualify. I mean, once the diagnosis is made, a patient as young as her late 30s may too benefit from HRT and absolutely should receive it. Yeah.
So we've spoken about HRTs. We've spoken through the symptoms of perimenopause. We spoke a little bit about when this happens, why it occurs. What else can somebody look to do before perimenopause in terms of exercise, lifestyle, diet? What else can we start thinking about before hitting perimenopause, and what should we increase or do even more of or change once we hit perimenopause?
So you have to move your body because any exercise has been demonstrated to be beneficial. Weight resistance training is advocated for because it protects the bones. A healthy muscle equals healthy brain. It has been shown to have immense effects on the perimenopause period, along with HIIT training, sudden spurts of energy. Generally speaking, consistency. I mean, if HIIT training is not your thing, or if weight resistance training is not your thing, or then anything, even yoga, Pilates, I mean, you really have to do what serves your body and listen to your body's cues, because this is a very volatile period, given the fluctuating hormones. So you have to really work with that and just remain consistent.
So, I mean, can we do anything to kind of delay or make sure that our symptoms are as optimal? Can we prepare basically for perimenopause before perimenopause hits?
Yes, absolutely. Yeah, I would say doing weight resistance training would be your best preparation.
Sorry, just can you get away with your little 4 kilo weights, or?
I'd say any weight resistance training, but the heavier the better. Yeah, obviously make sure that you don't injure yourself, do it in a safe space with a group or a trainer. But yeah, try lift heavy, just do it 2 to 3 times a week. There's actually no recommended guidelines. So I'm really speaking just from the bits and bobs of research that I picked up on, but just incorporate it into your daily routine and remain consistent.
I'm terrible at that. Such a Pilates girl.
Yeah, I would say, supplementing with Pilates would be a wonderful modality as well, because Pilates is also very, very beneficial. So maybe a combination of the two. And then perimenopause and diet. So generally speaking, similar principles to what we alluded to in the PCOS episode, and that is cut out on a diet that's highly processed, refined pastas, refined wheats, rather stick with fresh fruit and green leafy veg, legumes, seeds, nuts. These have all been associated with lower risk of menopause symptoms and lower symptom intensity and an increased quality of life. Whereas unhealthy dietary patterns, such as those highly processed foods that I alluded to earlier, sugars, spicy foods, alcohol, has been shown to worsen menopause symptoms. So diet really does have a role to play. What is quite contentious is phytoestrogens. Why it's controversial is because there were some really poor studies that came out in animal studies that suggested that phytoestrogens actually cause cancer because it links to estrogen receptors in the breast. But at the end of the day, this has totally been dismantled, and because the studies really were not conclusive.
That's like soybeans and stuff like that, right? Like tofu.
Yes. But at the end of the day, phytoestrogens are actually very healthy. Also, we do advocate for high fiber diets, because this can really help boost estrogen levels in the body. Not quite like HRT can, because I am a huge advocate for HRT, but it definitely can help.
Okay, so get your tofu at your supermarket today.
Yes, absolutely.
So I think we covered so much. There's so much more to unpack in this. I think we have covered an enormous amount already today. So I would say we'll wrap it up. It still sounds a little scary if I have to come back to, what I originally said. It still sounds like a lot. I think it still sounds like an enormous amount to process, but luckily there are other resources like hormone replacement therapy and more studies coming out around perimenopause that can hopefully help us to navigate this. And also hopefully knowing that you have or that you're in perimenopause can also help you to mitigate some of the symptoms and not think you're just crazy. So there is a silver lining.
Absolutely. And really our mission in this podcast episode is not to make you scared. It's to know that it's not in your head. Your symptoms are valid. Don't let any doctor or any healthcare professional, anyone, gaslight you into believing that your symptoms are not real. They are valid, and the future's looking bright because for once, women are being researched. And yes, it's an incredibly exciting space, and I'm really humbled to be working in this area.
Thank you so much for tuning in. We really hope you enjoyed this episode. If you do have any questions or you're dying to know more, please do drop us a message at the Ovarian Club. Please also don't forget to subscribe and to follow us. And yeah, we're here for any questions you have. And we're looking forward to a future episode on menopause, where we will dive more into the changes in the brain and more onto the lifestyle changes and everything to expect, so you can better understand what maybe lies ahead, maybe what you're going through, maybe what your mom's going through, your sister, your wife, your partner. So please tune in. Don't forget to share this with loved ones or people you believe would be interested in this. And that's it from us.
The Ovarian Club, powering life, nurturing health, shaping sustainable wellness. See you soon, follicle friends.